Good morning. Since I won't be able to join you for Education Day, I wanted to share a little bit from my perspective about patient-centered care. So I want to call this prioritizing patients. All right, I want to start with a couple of stories to illustrate what I mean about this. So over the holidays, I was at Mercy for 10 nights. Some of those were some of the busiest shifts I've ever worked. There was 8 and even 10-hour wait times in triage. Lots of boarding patients, lots of influenza. I'd get there for my shift at 10 o'clock and might go into a room, see somebody who just got room 20 minutes ago, but they've been in the ER for 6 or 8 hours, right? Sometimes the workup's been done already because there's just sort of standard things. Chest pain gets a normal workup. Abdominal pain, particularly in old people, gets a normal workup, right? So some of this, like CTs, labs, have often been done already. So I have a patient who's been there, I don't remember, somewhere in the neighborhood of probably 5 or 6 hours at least. 75-year-old lady, chronically ill, Parkinson's disease, lives in a nursing home, in the same nursing home as her 90-year-old mother, who is also there with her, and then a sister of the patient who's probably 70, who's actually in decent health. So the three of them are in the room. Mom and sister obviously concerned about the patient. Her concern is just nausea and vomiting. This has been going on for quite some time. They have a workup scheduled. They have a care or a visit scheduled with a GI doc coming up. They're reaching out to primary care to talk about this, somebody who comes to visit them in the nursing home. So I ended up doing a CT scan because, again, in old people with abdominal pain or abdominal complaints, they often have something bad going on. Long story short, she's got a diagnosis of most likely new endometrial cancer with mets to her liver, to her lungs, probably her adrenals, probably her pancreas, right? This is all brand new for her, right? They thought they were just coming in for nausea, vomiting. They were out of Zofran at home, so I could refill their Zofran, send her on her way. Right? All of that changes. This conversation changes completely. And when I went back in to go talk to them about this after I got the CT scan, I said to one of my colleagues that this is one of the most important things we do, right? Like, yeah, there's still 20 people in triage. I got 40 beds boarded in the ER out of 60 beds, let's say, right? None of that stops. Nothing else. Like, I still have workups on other patients going on. I still have nurses messaging me about stuff. Right? But all of that stops. This is an important conversation and arguably one of the most important things I do with patients, to have a good conversation at 2 o'clock in the morning about your new diagnosis of cancer and what that means for you. When I don't have all the information, I don't have all the answers, right? So everything stops for me, right? So besides criticals, if the other doc can't handle the critical that comes in or there's another one, yep, I got to step out for that. If there's a code green, which is our mental health patients that get out of control and need some meds, and everybody comes to that, security and everybody, right? I need to step out for that. Short of that, everything else is on hold, right? My work doesn't stop, but it's all on hold because this thing matters right now and it really matters to that patient. So my point in sharing this is that when we go see a patient, whether it is something super serious or they're super sick or not, we need to treat them appropriately, that this thing matters. And they called, this thing matters to them. And I realize there's tons of mundane things that we see in the ER. That stretch of nights, I saw plenty of influenza. A family member comes in with influenza symptoms and a fever, and the whole family has already been diagnosed with influenza A, and they're coming to the ER because they have the same symptoms, right? I don't know why people come in for that because it doesn't change anything, but they want to come in. I have to treat them just like everybody else. They get their time with me. We get a chance to talk about it, right? Those important things really matter. So when we go see patients, that's the thing that matters. Like this thing, whatever it is we're dealing with, that's the thing that matters. Second story, right? We represent medicine, and we not only just dying of fire, but everything about big medicine. So I was actually doing a ride along at Plymouth Police with a friend of mine. We got called out to a overdose. So a 20-something-year-old guy had overdosed the night before. This is now like a daytime shift, so like morning. He had drank a bunch of IPAs and took a bunch of Ativan, and he's just kind of passed out on the floor snoozing. The cop that got there before us put a pulse ox on, gave him a sternal rub, so he's kind of responsive, but not really. He's protecting his airway. His pulse ox is fine. His heart rate's fine. We don't have to bag him. We don't have to do anything crazy. We're just waiting for EMS to get there. So paramedic EMT shows up from another service. And so then we're loading up the patient. So patient lives with mom and dad in an apartment. So mom and dad are 50, 60 years old. They're awake and coherent. We're rolling the patient out. We got him up on the gurney and then we're taking him out. And one of the cops made a comment about the mega mover, that whatever device that the EMS service had, right? And something about cleaning it up or it getting cleaned, right? And so the conversation was meant to be sort of just friendly banter about this other device that we didn't end up using because the cops were helping carry equipment out of the apartment, right? And the EMT made the comment, yeah, they're supposed to get cleaned, but who knows, right? Or something to that effect, like questioning whether this piece of equipment that we're using in our care of patients even gets cleaned or not, right? And again, it was just meant to be friendly banter between the cops and EMS, but clearly you weren't understanding that there's coherent, like patient is passed out, but there's coherent parents there listening. So what do those parents, if they're paying attention to that conversation, which we have to assume they probably are, what do they think of us as providers, as first responders, as EMS, as ER, big medicine, and everything downstream, right? That we're making a derogatory comment about if the equipment that we even bring into your house to take care of your son even gets cleaned like it's supposed to, right? That's terrible, right? And I'm sure nobody meant ill by saying this, but by not paying attention, we're representing the brand. So that EMT, like, you're gonna have doubts like, God, you bring some dirty piece of equipment into my house that doesn't even get cleaned. So what are the downstream effects of that comment? Again, assuming parents are paying attention, like they don't have confidence in us as first responders, as EMS, they question the ambulance service, they question the ER that we're going to, they question big medicine. And clearly their son has lots of interactions with medicine. So this is not an isolated incident, like their only interaction with big medicine, but it's not a good one, right? It doesn't paint us in a good picture. So, and medicine has lost a lot of, like, people have lost confidence in medicine because the system is so broken in so many ways. But we don't need to pile on. We don't need to make that worse, right? We need to do the best we can to represent ourselves as a provider, representing our brand as Edina Fire, right? And representing all of medicine. So making comments like that doesn't help. I have the same issue at Mercy because there's a big, what we call the pit area, where a lot of the nurses and doctors all sit in the same area. We also have hallway beds that are literally just like around a half wall with a glass partition just to the, like, literally just outside of this area, right? So when we make comments in that area that are too loud, right, that doesn't bode well for patients that are listening or family members who are there just watching the show. And patients are sitting in those hallway beds for hours at a time. So they have a ringside seat to all of the bad things that we say, right? Do we have dark humor in the ER? Do we have dark humor in EMS and public safety? Yes. Is it appropriate around the dinner table at the fire station? Sure. Like there's part of commiserating about things in the system that are not great. We all know that exists, right? And some of that's getting it off your chest. You blow off a little steam when you're at the fire station, not within earshot of patients, right? Do I want to commiserate with my colleagues that everybody's coming in with influenza A when they already knew they had influenza A? Yes. Can I do that when there's patients listening and family members listening? No, that's not appropriate, right? So we have to be very cognizant of what we say and how that represents not only us as the individual provider, but everything that we represent. That little snapshot that patients and family get to the bigger system, again, which we all know is broken, we don't need to make that worse, right? We need to represent the very best that we can. And it's not that anything like on scene here, the cops weren't trying to like make it a derogatory comment, but just not paying attention to the words you use doesn't look good for patients. It doesn't inspire confidence in the system, right? You appear incompetent, or like that you don't even actually care if your equipment is cleaned, like you're not even a good provider, right? Like your demeanor. The other thing that I see similarly, especially young providers, there's EMS students that come through the ER periodically, and they walk around with hands in pockets, right? Does this portray professionalism? If you walk into a scene or with a patient, or you're just doing this slouched, hands in pockets, this sort of, no, it's terrible, right? Your hands are out, you're gonna do work. That's how you show up on scene. You don't show up hands in pockets, slouched attitude, dragging your feet, boots looking all dirty. Like everything that we do represents a snapshot of us and the big system to patients. And we need to make sure that we're doing that well, right? All right, in regards to demeanor when we're talking with patients. So in the ER, I'm notorious for walking fast, right? So everybody, it does a couple of things. One, I have to make my time as efficient as possible. So when I'm going between rooms, and I have some long hallways at Mercy, I am very quickly walking up and down halls to go see patients. When I'm at my computer, I'm as efficient as possible. I have to click through a ton of buttons, do my documentation, click orders, look at follow-up, look in the chart. Everything about that is as efficient as possible. When I walk in the room to sit down and talk to you, my demeanor changes completely. I am as relaxed as I can be. It's a rare exception that I don't find a chair to sit down and talk to patients. If family's already taken all the chairs, I will go out of my way to find a chair. I will sit down and talk to you. You maybe have waited in triage for 10 hours, right? You at least get time with me when I don't look hurried. And again, my workflow doesn't stop, right? Like I have nurses message me on the computer. I have things that I need to follow up on. I have people that I need to call. I'm waiting on callbacks. I have a phone that I carry, especially in the ER, that I get interrupted in the middle of talking to patients. I have to say, excuse me, I step out, I come right back. Everything slows down. We have an unhurried conversation for as long as you want to talk. And again, that's within reason. Patients that get really long-winded, I have to find an exit, right? But my point is, my demeanor is, I'm only there for you, right? It's not about me. Nobody cares. So my point is, it's not about you either. When you show up and talk to patients, it's not about you. Does everybody have frustrations? Yes. Does everybody have a personal life that doesn't go perfectly, right? You have a sick spouse, you have a new baby at home, everybody in the house is sick and nobody's getting any sleep, so everybody's cranky. You've had a terrible shift, you didn't sleep well, you're dealing with your own health issue, right? Your parents are sick, right? Like, everybody's got stuff. There's no exceptions there. Everybody's got crap to deal with. But when we talk to patients, that's not the place for that, right? It's not about you when you're talking to patients. Do you collaborate with your colleagues? Do you commiserate a little bit? Do you sort through some of that stuff, right? And the dinner table is a great place because we want work to be a supportive place, right? So if you got stuff at home and you're dealing with, right? Like, the fact that firefighters get that time with each other in a fire station, I think is a big benefit compared to like cops. They don't get that. They're on shift. They don't eat and sleep and talk with the same people that they're on shift with, right? It's a very different thing. There's different culture there. So that's obviously a good thing. And you can talk about things that are frustrating. You can sort through things. Talking is thinking. So all of that is good, but not when we're with patients, right? The only thing that we care about when we're with patients is the patient, right? All of my stuff, all my personal stuff, doesn't matter, right? That's not the time for conversation about any of my personal stuff, right? And then I'm efficient in everything else that I do so that I can take this time with the patient, because everything else I'm going as efficiently and as quickly as I can to make sure that that all works out. So I have this carve out time when I'm with you. Take all the time you need. We're going to be nonchalant. My posture is relaxed when I'm sitting there. I'm not standing at the doorway ready to walk out of the room. We got time. Tell me what's going on, right? So that's huge. It's not about you is the takeaway. Couple last little thoughts. Again, prioritizing patients versus performative medicine. And we've talked about this before. We've talked about you're on body camera with the cops when they're on scene. There's bystanders on scene with a cell phone out, right? But we do good medicine and then it looks good, right? This is not the other way around. We don't fake that we're trying to act like we're doing good medicine, right? We do good medicine and it looks good. So this is a secondary, the performance, the camera, when we're in view of the public, we're on everybody else's body camera, when we're on cell phone camera, it looks good because we did good. We have to get that correct, right? This is the thing that matters. Taking good care of patients, and then the perception of it, and anybody viewing that is going to look upon it favorably, right? So we got to get that in order. This thing matters most. That's a secondary benefit. How it looks is a secondary benefit to the actual good care that we provide. Our default is to transport patients. We take them where we want to go, or where they want to go within reason, right? STEMIs, traumas, strokes, right? We have some limitations there, but generally speaking, we show up, we assume we're going to take the patient where they want to go. And that's across the board. It doesn't matter how they're coming in, who they come in with. We take care of the patient when we show up on scene. In regards to recent stuff with ICE, right? Nothing changes. We prioritize the patient. We don't fight with anybody. And those are I don't ask you to put yourself in harm's way. Those are universal things, right? Prioritize the patient, take them where they want to go is our default. Are we fighting with anyone, obstructing anyone, right? We're not getting into the politics of ICE and what they're doing. We take care of the patient, right? And we don't fight with anyone, and I don't ask you don't put yourself in harm's way. So whether that's any contentious things that are happening on scene with local law enforcement, with ICE, none of it matters, right? We're taking care of the patient. We don't fight with anyone. We don't go in harm's way. If there's things that are problematic in that, raise it up the flagpole. Get your captain involved. Call a chief if you need to. So again, our default though is to transport patients and take care of patients. That's the end goal, right? That's what we're all about, is taking care of patients. So hope this helps. Happy to answer. Obviously, I'm not there in person, but happy to answer questions offline. If this comes up more, we can talk about it in the next training. So have a good day.